Welcome to the deep dive. We take complex clinical stuff and make it make sense for you. Today we're digging into a really big change in heart failure management, specifically HFrEF, heart failure with reduced ejection fraction. For years, decades, the big question was always beta blocker first or the RAS inhibitor, the ACE inhibitor or ARB, which one goes first? Well, our mission today, to show you why the evidence basically makes that old debate obsolete. It's all about therapeutic urgency now.
Yeah, it's quite a shift. We've gone from this really cautious, slow, start one drug, max it out, then start the next approach, to something much faster, rapid, comprehensive treatment with what we now call quadruple guideline-directed medical therapy, or GDMT. It's really the standard now.
That sounds like a huge jump, especially if you were trained in that older patient titration model. But the main takeaway for you listening is this. The speed of getting these meds on board is what really moves the needle on outcomes. Not so much the order of those first two. It's about maximizing that time to benefit. Okay, let's talk about this dream team then. The four pillars of what's sometimes called comprehensive disease-modifying medical therapy. We've got ARNIs, angiotensin, receptor neprilysin inhibitors, then the evidence-based beta blockers, the BBs, mineralocorticoid receptor antagonists, MRAs, and the newer ones, SGLT2 inhibitors.
And that ARNI point is key. They're generally preferred now over the older ACE inhibitors or ARBs because they do two things right. They block the bad RES activation and they boost the body's own protective peptides. It's a smarter dual approach the old drugs just didn't have.
So if these drugs, or most of them, have been around, why the change now? Why the push for speed?
That comes down to something called clinical inertia. Basically, it's the tendency to, not start or increase therapies when guidelines say you should. Doctors are maybe too hesitant. Patients ended up spending too long on doses that weren't really doing the maximum good, subtherapeutic doses.
And the data on speeding things up is pretty stark, isn't it? I saw these modeling studies. They showed rapid initiation, like starting 2 to 4 of these drugs pretty much together or in quick succession. It dropped the estimated 1-year mortality risk significantly, from about 6.9 deaths per 100 patients with the old way down to maybe 5.2 to 5.4 per 100.
That's a huge difference just from changing the timing, essentially compressing the timeline. And importantly, while getting all 4 on board quickly is ideal, the modeling actually showed that a lot of that survival benefit, it's sort of plateaued after getting just 2 meds started at that first visit, which gives clinicians some flexibility,
And crucially, the safety data looks good. The overall risk of side effects wasn't really higher than the slower approach. Right. Flexibility is important because it's not like you just throw all 4 at everyone instantly without thinking. It has to fit the patient's situation, their blood pressure, heart rate, whether they're fluid overloaded. That all matters, doesn't it?
Exactly. Think of it like this. The old way was like building a house brick by brick, very slowly. Now we realize the patient's heart condition is more like a fire. We need to get water on it fast from multiple hoses, but we still need to aim those hoses carefully. So 2 main things to watch for. Constraints, if you will. 1, if someone's acutely decompensated, really fluid overloaded, you absolutely delay the beta blocker until they're stable and dried out. And 2, if their blood pressure is low, say systolic under 95 or 100, you prioritize the drugs that don't drop blood pressure much initially. That usually means starting the SGLT2 inhibitor and the MRA first in that situation.
Okay, so for someone stable without those issues, the path seems clearer then. Maybe ARNI and an SGLT2 inhibitor are good candidates to start rapidly together, especially since you mentioned SGLT2Is show benefits so quickly, like within weeks, and they're generally easy to start tolerance-wise. Less BP drop concern.
Precisely. For the stable patient, those are often great lead-off choices, the ARNI being the preferred RAS agent now. The SGLT2 are really attractive for rapid start because, those benefits kick in fast, 14, maybe 30 days, and they tend to be well tolerated right out of the gate.
So pulling it all together, the big lesson is?
The lesson is the conversation has shifted. It's not which single drug first anymore. It's how fast can we safely get the patient on the full synergistic quadruple therapy. That combination, achieved rapidly, is what truly maximizes survival and improves outcomes. Speed is life in this context.
Okay, fascinating. So here's a final thought then. If the evidence shows this faster approach doesn't actually increase side effects overall, what else, beyond just updating treatment algorithms, can we actually do to tackle that clinical inertia, that sort of cultural resistance to moving faster? How do we make sure patients actually get these life-saving therapies quickly and aren't stuck on suboptimal treatment? That seems like the next big challenge.